I'm very pleased to begin by introducing Jerry Freed, who needs no introduction to this SAGE's audience. But Jerry is chair of the Department of Surgery at McGill. He is, if any of you were at the awards luncheon, you heard a fitting tribute to Jerry, and I can't begin to repeat that here, but he's been a mentor and leader to many of us in the area of curricular development and standardized curricula and valid measurement tools in the area of endoscopic and laparoscopic skill. We're delighted to have him lead off the program. He's going to talk about FLS and FES programs. What are their roles in surgical education?
Thank you, John, and thank you, ladies and gentlemen, for attending this session. Two of the real icon projects of SAGE's educational programs are the FLS and now the FES program. And my talk is really designed to introduce these programs to you from the perspective of how they can play an important role in surgical education, particularly at the residency level. I have no disclosures of conflict with respect to the content of my talk. Can I have the next slide, please? I will do it myself. I apologize. Try this again. So I think most people would agree that if you look at the breadth of the content area of general surgery, it truly is gastrointestinal surgery, and it's estimated that 70% or more of practice of the general surgeon relates to gastrointestinal surgery. And in this day and age of the modern practice of GI surgery, the tools in the hand of the surgeon are primarily the laparoscope and the flexible endoscope. If you accept that, then the question is, how do we best prepare our trainees to be competent GI surgeons and to be able to utilize those tools in as effective a way as possible and to ensure the safety of the patients that they practice on? There's been an evolution in surgical training from a primarily one of experiential learning to one that's been more focused on a defined curriculum-based training. In the past, the primary metric or measure of proficiency was how many cases or procedures someone does. And nowadays, we're moving away from case numbers and we're moving towards validated objective measures of proficiency. So FLS and the new program FES are good examples. They're real models of defined curriculum-based training programs that are associated with validated metrics that can be used to verify learning. So you're not only training someone, but you're verifying that they've acquired the knowledge that you want. We have to recognize the context in which surgical education is evolving, and everybody is aware of the impact of resident work hour restrictions on our ability to train people experientially, because the amount of experience is somewhat random, and it really depends on what happens to come in the door during that 16 hours that the resident happens to be available to take care of them. At the same time, the complexity of knowledge, medical knowledge, continues to increase at a rapid rate. And the reality is, at some point at the end of the training, these newly minted general surgeons have to go out there and to practice, and they have to meet the demands that are put upon them when they go into their practice environment, which may be different from their training environment. Our trainees and our surgeons are increasingly accountable to the public, and hospitals and various other credentialing agencies are really interested in some defined criteria for privileging. On top of this, there is some political competition between specialties, so that different specialties have different ideas about what it takes to form a competent surgeon, or more particularly an endoscopist, depending on the route that they've gone. And so by having a standardized way of measuring proficiency, we can get around some of these issues. We have to recognize that everybody goes through a learning curve, and the learning curve is a phase where people are acquiring skills, knowledge, etc., at a relatively rapid rate before it starts to stabilize. So it's the relationship between your experience and your performance. So what are the opportunities for SAGES as an organization? We can be there to define the curriculum, the learning that someone has to do to be competent. And that curriculum must include the knowledge, judgment, and the technical skills that form an effective surgeon. And then we could use metrics that are objective, sensitive to the appropriate differences we want, feasible to use, that form milestones that really reflect the competence that a person is acquiring. So how does one develop proficiency? You have to learn correctly, then you have to practice deliberately. You have to practice with a goal in mind, and that goal should challenge the learner. You have to embed a process of evaluation, and you have to use that evaluation to provide feedback that is individual and constructive and specific. So it's not to say, Dr. Pellegrini, you're not a very good gastroscopist, but it's, Dr. Pellegrini, you're having trouble retroflexing the scope so you can't see the esophagogastric junction, and this is what you need to do to get better. And I know that's not a problem with Dr. Pellegrini, but it is the way that you give feedback in a constructive and specific way. By identifying these specific needs based on your evaluation, then you could generate exercises or practice for people, embed reevaluation, and I would advocate that one of the greatest ways that this can be done is simulation, because then you could really define the content, the level of difficulty, and you can embed in it appropriate metrics. What do FLS and FES have to offer? Well, they both do have a standardized curriculum. They've been developed by expert faculties that are widely spread. So unlike any of us that may want to develop a program in our own institutions, the FLS and FES groups have been able to draw on expertise that reflects a variety of knowledge and skills that's geographically diverse, and it's not a single culture. Each of these curricula encompasses the knowledge, judgment, and skills that are really required to be excellent in the field. Each of them have both didactic and hands-on components, and they utilize the newest multimedia opportunities to provide the information rather than static textbooks. They can be distributed electronically, and the benefit of that is it makes it much easier to update the material to make sure that it's current. The unique properties of these two programs, however, have really been the development of metrics. And these metrics provide reliable and valid measures that have met the standard or are designed to meet the standards of the same high-stakes exams that are used for certification programs. They have also been developed with a relationship between what we're measuring on the test and how people perform in the clinical environment. And we're going to hear more and more about that during the subsequent presentations. And FLS, which is certainly more mature than the FES program, has also been able to generate the highest level of evidence through randomized controlled trials to show that the training in that program in the simulated environment of laparoscopy is transferable to the real world, and the efficiency of training in this environment is extraordinary, so that it takes you less time to spend acquiring the skills in the simulator than it would if you were just acquiring those skills by patient after patient care. And that's a very useful piece of information, because it allows us to make sure that we use the educational time appropriately. Now, the American College of Surgeons a few years ago came up with a classification for verification of surgical knowledge and skills. And both of these programs perform to the level 3 category, which means that it's an educational program where the acquisition of knowledge is confirmed by a process of verification. And in both of these projects, the methods of verifying the knowledge and skills were put together using the same type of process that you would use for a high-stakes examination. So they're very carefully done. It's not just the traditional pre-test and post-test that may be questions that you randomly generate. So the other thing that I think that's really useful about FLS and FES is that they teach us the importance of metrics in residency education. What are metrics? Well, metrics are measures, but they are more than that. They really define your value system. What you measure is what people will aspire to. And so if you just want surgeons to be really fast, you measure time. If you want people to avoid errors, you add errors to the time. And so you, by setting the metrics, you set the agenda for the educational program. In the FLS program, it was decided a priori that the metrics would be designed to reward two main properties, efficiency and precision, with penalties assigned for very specific errors, including some errors which would be catastrophic and result in a score of 0. So it's like the real world. I mean, if you tie a knot and the knot doesn't approximate the two things it's supposed to sew together, then it doesn't make a difference how pretty the knot looks. So you could define the metrics to reflect the values that you want. The other things are that the values of metrics measure are measured in a way that is objective, so it doesn't involve any, I think that was a pretty good knot or a pretty good colonoscopy, but they're objective measures. And by being objective, it means that they can be administered in a reliable way so that the raters that are measuring the performance are likely to agree on the score. And that the metrics have been tested for validity to make sure that what we're measuring reflects what we want to measure, and that is the technical skills or the knowledge in the real world. So the importance of metrics, I think, is one of the things that has allowed these programs to generate a lot of buzz. In the course of an educational program, they provide what I had mentioned earlier, objective, meaningful, and timely feedback for the learner. They provide a reference point so that each learner can reflect on how they're doing compared to their peer group. It could set a goal for them. But in order to do that, it must be credible. What you're measuring must be understandable to the learner. They must believe that what you're measuring is important. It has to be practical to administer, and it has to be, as I said earlier, reliable and valid, and predictive of performance in the real world. Once you have these metrics and you've associated with the educational program, they could be very helpful in verifying that the person has learned. They can be used for certification or credentialing in a more final way. Now, what can we achieve with FLS and FES? It allows us to set the curriculum, as I said, and once we have defined that curriculum and we have it in a uniform way, we could teach it properly, because we are not only giving the content, we're giving a way of educating using that content. That allows each individual person to proceed at a pace of their own choosing, really, that reflects their way of learning. Along the way, we measure performance, we set realistic, consistent, and objective goals, and these are the proficiency levels that they aspire to, and we could set milestones for them to achieve that. And then the nice thing is that each of these programs has been tied to a metric that we've developed for the clinical environment. So for FLS, we have an outcome measured as we call goals. I think we'll hear a little bit about that later. And for flexible endoscopy, we have a metric which we call gauges. And so those outputs in the clinical environment actually could generate measures of the areas of deficiency. That then can be reflected on how we designate the learning program for the individual person to build up their skills where they're missing. So I think one of the offshoots of these two programs is it did lead us to come up with measures of performance in the clinical environment, because we recognize that the in-training evaluations that we traditionally used have been very limited, and that these gauges and goals have gone through the same process of validation to make sure that they are specific, objective, standardized, reliable, and valid. And they provide, because they're specific, they provide specific feedback that can be used constructively. So each aspect of performance is broken down and measured, and therefore you could see where you're doing well and where you're not doing well. It also forms the gold standard for us to evaluate our curriculum, because we have to make sure that our curriculum has an impact on clinical performance. This is what goals looks like, and just very quickly to show you, it really looks at 5 different domains of performance: depth perception, bimanual dexterity, efficiency, tissue handling, and autonomy. And each of these is scored on a 5-point Likert scale, where there are very clearly defined anchors for what a 1, 3, and 5 is for each of these. And it allows, at the end of every case, we could use this to actually tell our residents how they're doing. It takes a minute to fill this out. We actually usually get our residents to fill it out themselves, get the attending to do it, and then you meet afterwards and you discuss it and you come to some consensus. And then you could track performance over time and actually see how people are doing. And it's proven to be extremely important. Now, this is a typical learning curve. As you can see, there's a rapid phase of early learning. I don't know if, can't quite see this laser pointer, but there's a rapid phase of early learning and then a slower phase as you go over time. The lower left-hand arrow really reflects what we achieve if we start learning in the clinical environment. Our feeling is with FLS and FES, you can go through the rapid phase of early learning and then start people in the clinical world when they're closer to the plateau. So there's a lot of bang for the buck in this way. We've also shown, this is just some data from the FLS program where the score on the simulator, which is on the horizontal axis, is highly predictive of the score in the clinical environment with 95% confidence intervals around the line. And then we could identify a goal for our residents by saying, well, what is the score for a chief resident in the simulator if they're going to get a goal score of 20, which is a high-performing score in the lab? And then identify what the relationship is between what the goal we want to set in the simulator and what the expected performance will be in the lab. These are just quickly the results of a randomized controlled trial of FLS-based training versus conventional training and performance during the lab COLI. On the vertical axis are the scores. The top graph represents FLS, the bottom graph represents clinical performance using goals. And you can see the control group, although they improved slightly, the trained group improved much more, and they would all have passed the FLS test. On the lower bars, you see the control group over time showed relatively little improvement, whereas the trained group, by training to proficiency level, increased the equivalence of going from a PGY1 to a PGY3. And the average amount of time that it took was less than 8 hours, and most of that time was self-study time. Only a couple of hours had to be mentored. So very efficient. FLS has been proven to be feasible to administer in a large scale. There's a network of proctors that are out there, and the cost of it really is equivalent to a good textbook or attending a single meeting. The curriculum is provided free. For FES, how are we going to acquire the technical skills to perform flexible fiber optic endoscopy? Well, you have a few choices. You could learn it on the patients. You could learn it in high-fidelity simulators, the picture of a couple that are out there. And SAGES has engaged in this STEP program where we provide to the training programs full endoscopy towers that they could use for training, and they could use animal parts, they could use boxes, etc., in order to get their skills. But the FES will be the way to verify that they've acquired those skills. So just to put this all together, FLS and FES should be embedded in residency training from the junior years on. They could be used to identify milestones for your residents. The goal is to teach and verify fundamental skills that are early on. Let them learn the good habits, and that will form the basis for their procedural training. So they're learning the basic skills, the so-called alphabet, that they could then put together to generate their language. These skills are the floor for the foundation of the training. They're not the ultimate goals, and they could be linked to clinical performance. In order to do that, it's useful to have a simulation center where people can be away from the clinical environment and to learn. And ultimately, if we want people to be good surgeons, they have to put together the knowledge, judgment, and technical skills. Thank you very much.